First of all, I want to start by thanking all the organizers for putting this meeting together and all the speakers actually for a really superb two-day scientific discussion, and the data that I've seen is absolutely mind-boggling as to how much progress has taken place in this field. From skeptics to actually showing that there is real data here is really, in a very short period of time, is unprecedented in my mind. So, I like to make this more of a dialogue. I like to learn from you, and I like to hear your views. Over the short period of time that I've been involved in this project, we've actually made huge strides, but in part, that is because of the feedback we've received from the community and from other scientists who are working in the field. So I want to take advantage of that opportunity over here. A lot of what we do is already on the web, and most people can easily access that kind of information. So I'll give you a little bit of where we stand and how we organize, and then I'd like to be able to engage you in a dialogue. So first of all, as you heard the previous two talks, one from CDC and the other from NIH, you can see that the NIH, the US government, is very vested in this disease entity. The Center for Disease Control and the National Institutes of Health both have a common boss, and that is the HHS, which is Health and Human Services, and we all report there, right? And so the funding flows from there to these agencies. NIH, as you can see, decided that NINDS, which is the Neurological Institute, should play a lead role. And that itself shows you that we think that this is a neurological illness. And as you can see, Vicky has done a superb job and engaging all the various institutes, various agencies around the world in a very short period of time. And although we are both part of the same institute, actually, it is gratifying to see that she's doing so much stuff that I have to come over here to actually learn all about it. and that is because we're both moving so fast, right? We really are. So the way it is organized is you have an extramural program, which Vicky heads, and that is 90% of the NIH budget goes extramurally. So that means that people apply for grant funding, and that money flows out to support all the other research. And NIH is unique of all granting agencies around the world, where the money flows not just within the United States, but anybody from any country can actually write a grant to NIH and get funded. So there are a lot of international efforts that get funded by the US government, okay? But then you have an intramural program, and which is this hospital here, these three buildings that you see here. These together are called Building 10, which is the Clinical Research Center. Okay, so on campus there are a total of 70 buildings, and these three together are where all the clinical activity takes place. Okay. So, and this is the only research hospital in the world where the only reason patients come here and get admitted or to the outpatient clinic is because they're participating in some kind of a research program. So nobody can walk in here and say, please take care of my disease, okay? There's no emergency room over here in this institution, okay? So, and it's a gated place, so you really have to have permission to enter in there. And that's true of all federal buildings these days, unfortunately. So, so I see patients in the first two areas of where we have a lot of our activity. And in the last building that you see over there is where my office is, and my lab is situated there. And also our inpatient services take place there. Okay. So it's very easy for me to transition from the bench all the way to the bedside and back and forth at the same time. And so, so the way the place has been organized also aids research. The other unique aspect of it is that we can admit patients there for as long as we need to study them. So the way we've designed our study is that we have very rigorous criteria for identifying patients that we want to study. We've decided to focus on those individuals who have a clear infectious process that then triggers the illness. Okay? So once they meet our criteria, they come over here, we admit them for a total of 10 days. Okay? And during that period of time, we do extensive battery of investigations. And then we look at all what we have gathered. We want to make sure they don't have some kind of underlying disease. And interestingly, despite all of that, occasionally we do find that some patients actually have some other illness that is mimicking their symptoms. But then we have a committee of 5 people who are experts around the country in this illness, and we go over the entire records and decide whether this patient truly meets all the criteria and now should move on to phase 2, where we would bring them again, and this time we challenge them with an exercise test and collect various kinds of parameters on them before and after to try and study the illness. So it's a very involved project. We have a total of 40 patients that we are recruiting for this study, and another 40 control patients that will be studied. Okay? And we anticipate that the study will take about 4 years to complete, but we've made tremendous progress in this period of time. So we've already got 16 controls and 13 patients through the first phase, and we have a number of subgroups, sub-studies also, to try and understand what PEM actually means, a number of new testing that we're doing on these patients. So we piloted them on healthy volunteers. So the whole sorts of other sub-studies are ongoing at the same time. Okay. The other thing I want to emphasize is that although we are doing this all intramurally, we are happy to collaborate with anybody. And a number of you have already expressed an interest in various samples that we're collecting or participating in various ways. Some of you have actually come and visited us and given talks to us, and we've learned from you, and we've had the opportunity to showcase what we do and get feedback from you. So you're always welcome to contact us at any time. We also make a huge effort to try and communicate with the community. So Vicky has spearheaded a conference call every month that we participate in, and lots of patients and other groups get on the call. They ask us various kinds of questions, and we're absolutely delighted to answer them the best we can. And if we don't have the information, we're happy to dig it out and provide it to you. Okay. So we have a really open book policy, and every question gets answered, every email gets answered. And you're welcome to, and sometimes the NIH system is quite complex to understand whose role is what. But it's okay for you to direct all questions to me, and I'll find the right person who can answer them for you, okay? And so one other person I should introduce is Brian Wallet. Where is Brian? There he is, okay. So this study would not be possible intramurally if it weren't for Brian, okay? So he is very strongly committed to the study. All day-to-day activities really take place because of him. And he screens all the records, he beats all the patients, he makes sure everything is coordinated, and he provides very unique insight from his own expertise, which is in rheumatology. And he's a very organized person. So I really want to acknowledge his help, and thank you very much, Brian, for everything you do. And he has put together a fantastic team of people. So we have a nurse practitioner, a nurse, we have a patient coordinator, and there are 2 other post-bac ERDAs, what we call them, the young people just finished their undergraduate work and worked with us for a couple years. And so that clinical team is absolutely critical to make sure that everything goes as clockwork as we plan to do so. And then we've got a whole host of other laboratory researchers who really take care of the rest of the, and most of them are donating their time, efforts, and resources to work on this. So all of us who got engaged into the study already had a daytime job, okay? And this was added on top of it, but we're happy to do it, and we learn a lot from it. And what we learn here informs what we do in other areas of our research. And we're happy that we can have this nice joint feedback from both aspects. So I'll stop over here and take any questions if there's time. Otherwise, we can do it as a panel if you prefer.
Well, now there's an interesting talk. He's asking for awkward questions they can't answer. So come on, give him them. This is your chance. Could you say who you are, please?
It's Paul Watton, I'm a patient. So you announced that you were going to do some quite creative biology and testing. Since you've got into the study, is there anything else that you've thought along the way as a result of what you're doing, which you now think might be additional to the original plan?
Yeah, so there are we've added a lot of things, but there are two major things that I can tell you we had not planned for originally that we've added. One is a skin biopsy and the other is a muscle biopsy. Okay. And so the skin biopsy is for the purpose of looking at the nerve fibers in the skin themselves. So that technology has really advanced in the last couple of years where you can really do a very interesting biochemical studies of those nerve endings and learn a lot about what's happening in the peripheral nervous system as well as oxidative stress, all kinds of things. So that's one thing we've added. And the second thing is we've added the muscle biopsy because we found that actually some patients who may even have diseases that affect the muscle itself that can look just like ME/CSF. So that's one reason. The other thing is that's the best place to look for mitochondrial DNA because that can be quite different in the muscle compared to blood. So for a variety of reasons, we have now started looking at muscle and nerve.
Okay. Any other before we start the panel? Yes, sir. Yes. You are?
Don Tannenbaum. And a quick question. It's really exciting what Vicky has been able to accomplish in the last couple of years, and really we very much appreciate all of Vicky's efforts. She's done a phenomenal job and worked extremely hard to do that. But one of the things I noted what you said is that you have a team, a clinical team, and then you have the analytical team that analyzes the results. But that group seems like it's an add-on job, that they have a full-time job and then they're volunteering their time. Isn't it possible for them, for the NIH, to actually hire, full-time in that group as well? Because it could help speed up the process. Because
so there's no barrier for us hiring people. So if we need people, we'll hire them. A lot of the samples are going to get processed towards the end of the study anyhow. So because, if let's say you're doing, exome sequencing or whatever, if you do it on each patient as they come through, the technology is not the same today. It's going to be 4 years. You won't be 4 years from now. You won't be able to compare them together. And some of these things are better just farmed out to commercial places to do them. So those are decisions we'll make as we go along, but there's no barrier for us to hire people if we need to.
Okay, Avi, why don't you come and join us on the panel and we can let the questions flow now. Yes, sir, you go.
Just one question about how, in your experience now, how common are multiple infections like cytomegalovirus plus borreliosis plus ehrlichiosis and things like that?
So what it requires is that the disease should have been triggered by an infection, okay? So that, I think, is the important criteria. If they have subsequent infections, it doesn't exclude them from the study. But the documentation of that infection is critical. So they have to be sick enough to where they saw a physician and the physician actually documented it in some kind of notes. And that is a very rigorous criteria, but that's the only way to be absolutely certain we have the right population.
Okay, so come on. A few years ago, we didn't have any of this. It's all started. Put them right, please. Give them some ideas, suggestions, see if things are going.
Yeah. We're here.
Yes, go on.
It's very good to have you, to welcome you all here. It's been terrific, and it's good to see the enthusiasm you've got. And so I appreciate that very much. And you're certainly on the ball and moving things. But I noticed that you are finding things that go way back in our experience. The school attendances thing reared its head a long time ago. And the other thing that I noticed, I think it was Beth who mentioned it, the question of vaccines. Vaccines are a vexed question, I think, for people with ME. And many people, clinical investigators, have people with vaccine damage appearing on their clinics because they've nowhere else to go. And the medical directives really are, all vaccines are good, no ones are ever bad, there's no ever problems with it because we want the herd immunity kept at the highest possible level. So I just wondered if we mentioned HPV in the meetings yesterday. I just wonder if you'd like to just comment a bit more about your attitude toward vaccines and how you handled it, because it's a difficult political issue as well.
Yeah. So we take it the whole vaccine question very seriously, and the other part of my life really is HPV. I'm an HPV laboratorian. I'm a pathologist by background. I've done more HPV than other things, and so this is the first time that the two parts of my life have actually converged on the same question. So we are trying to come at ways to look at this very carefully. The epidemiology of who gets vaccinated and the age of vaccination and the age of onset of the POTS and autoimmune illnesses are very similar. So it takes very careful and large studies to really look at this and get a concrete answer. So far in the US, we've not found evidence that they are linked, but we want to establish additional systems to continue to monitor and look for it. We also feel that the process of engaging one of these health centers, it'll be something like the Kaiser Group, getting them attuned to how they would identify ME/CFS cases in their own population, again, will show them that they need to start caring for these patients. So we think we have multiple aspects to gather. And then sort of just to comment on your question of like reinventing the wheel or finding things that we already knew, I feel that what we're doing is we're capitalizing on what we knew to gain more information. So we didn't have a way to really gather significant amounts of data on pediatric ME/CFS because it's rarer, and in the prior study designs of populations, we weren't getting enough cases. But if we can get a school-wide surveillance, then we will get this information. We have worked on pediatric ME/CFS and have a whole section on our webpage which has materials for schools, for the nurses, for the teachers, to try to help boost up the educational needs of the children that are affected.
Okay. Yes. Yes. And then I'll take two more.
Just following on from that, so with the data that you have to date on pediatric ME, do you distinguish between pediatric ME and adult ME in terms of the way it presents and the symptoms, or do you see it as one illness? Right.
We see it as one illness, but recognize there are differences in that POTS is, the orthostatic hypertension is so much more prominent in the pediatric group. We don't have a way to distinguish it other than age of onset at this point, but again, we need more data. First of all, I'm sorry, I really should have changed the way I presented that. The 42% refers to, that's the population that was surveyed. So 42% of the people that responded to the survey were female. 82% of the patients were female, okay? So I'm sorry, just to make that very clear. And then as far as the prevalence, one of the limitation with this approach is that we're dealing with self-reported illness. And when you do that, there's going to be some false positives or false reporting. Nonetheless, it is a way to start putting the picture together. And so we are not surprised that the figure is higher. And that's why I linked it to the Canadian data, which uses the same basic kind of self-reporting system, and they're finding the same prevalence. I mean, that's the pros and the cons. Okay, the con is that that the overall illness pattern may be less severe than the patients that present at clinics. But this is a problem that public health is used to. So when we do surveillance for many things like influenza, we accept an influenza-like, realizing there'll be a lot of other colds and things that aren't influenza that end up contributing data. And then you compare it to data that you get from the clinics on a smaller population, and you can say, okay, this is how we can interpret it. So it's still useful data.
So I think the commitment from NIH to NINDS shows that, yes, we believe that the neurological aspects need to be investigated. And that's basically what we're trying to do, is trying to determine and show where the neurological problems really are. So if we already knew that's what it was, then there's no point in doing the study. So we're committed and we're doing functional MRI scans, we're doing transcranial magnetic stimulation, we're looking at spinal fluid. We're trying to find what the abnormality really is. And that's the only way to really convince people whether this is or is not a neurological disease. And that's our commitment.
And just to answer your question about following up on the patients, the study design and the IRB is not to do follow-up on the participants. We're trying to get people to answer the phone and talk to us. So there will need to be additional kinds of studies to really flesh out and understand the data, but it won't be directly linked to BRFSS unless we do an amendment to that and try to tack it on.
Okay, yes, there was a gentleman just behind you. Did you still want to ask a question?
Yeah, I wanted to say how gratified I was by how much Dr. Zunger and Dr. Whittemore have managed to generate in their areas. And I'd like to ask Dr. Nath two things. I know that he himself is an expert in neuroinflammation and including, I believe, investigations in the area of HIV. And at the same time, we have Dr. Unger, who is, as she just alluded, has done a great deal of work with a cancer form, with HPV, or precancerous. And I just wonder, there's so much work going on in both HIV, which gets 10% of the US budget by law, the research budget, and in the Cancer Institute, that I'm looking for cooperation, and I wonder if either of you have thought of reaching out and if there would not be gains of scale or gains of cooperation in both avenues, with which both strongly characterize this disease.
So let me just put it this way. So yes, you're right. Most of my career I've studied retroviruses, particularly HIV infection. And a lot of what I'm doing for MECFF is from the knowledge that we've gained studying HIV infection. So all the immunology that I do, for example, just look at all the chemokine receptors, which are really critical in neuroinflammation. All that biology was developed by studying HIV, okay? Most often, advances in a particular disease comes from information that may come from a totally different disease per se. So once you start understanding biological mechanisms of one disease, they inform that of other diseases. And that's throughout the history of science, that is really the case. So yes, there's a lot of cross-fertilization between these diseases because the underlying biological systems are the same. It's still the same brain, right? It doesn't matter what virus or what disease gets afflicted, whether it's Alzheimer's or Parkinson's or whatever it is. If the neuron is degenerating and you're studying the process of neurodegeneration, it's going to be applicable to all of them. It doesn't matter what the underlying etiology is. No.
One last question.
Can I comment quickly, Ian? I wanted to comment that we have a representative from the National Cancer Institute on our Trans NIH working group, and so they are actively interested and involved in finding ways. And one project that I'm aware of is that the National Cancer Institute, together with the National Institute of Aging, has now funded 4 groups to develop new ways to measure fatigability, which I think will be really applicable to studying fatigue and post-exertional malaise in ME once they develop their new methods. So we are in communication with them all the time, and there's a lot of crosstalk on an ongoing basis.
A question for Dr. Nath, but maybe the panel as well. I've been following a lot of the HIV genetic work that's shifted over the last 5-10 years in Edinburgh, University, San Diego, places. I'm also looking and aware of the increase in genetic work into the treatment of TB, as opposed to the medical, but the genetic side. And I was just wondering if any of you are thinking there's a direction there in the genetic evaluation, genetic studies, looking at CFS-ME as opposed to on the clinical side.
Yeah. All right, and we'll take the last question, and then the panel can take whichever one they want, okay?
Well, this is not a question, a comment. The new worldwide classification, international classification of diseases, version 11, will come into use this fall or at the latest next year. Right. And chronic fatigue is clearly defined as a neurological disease in Chapter 8. And also postural orthostatic tachycardia is defined as a neurological disorder in the same Chapter 8. So that's, I think, important that it's clearly defined, and that is international WHO, World Health Organization.
Okay. So the first question, the genetic side of it, please.
Yes, so not just us. I think a lot of people are interested in genetics. Genetics is now the new fashion. For any disease, everybody wants to know what the underlying genetic causes. It's not easy to figure that out because all the autosomal dominant ones have already been discovered. You're looking at polygenic diseases now, so you're looking at small effect sizes, multiple genes, and those are harder to find. So you really need very large sample sizes, proper controls, but there's so much genetics ongoing that I think you'll see a lot of data on ME/CSF being done. What comes of it is going to be harder to interpret, I think.
Yeah, we're talking about an international collaboration to be able to get that done, because in the other part of what I do, which is epilepsy, we've been able to develop a worldwide collaboration to collect 25,000 samples that are being sequenced in the United States. And that's sort of the level that you need. And it's going to require multiple groups across the world, I think, to accomplish that. But I think you're right on with understanding the need to do that at this time.
Well, can I thank the panel from coming all the way, and don't come back again, please, until it's solved. You're very welcome next year, and we want to see the results. Thank you very much indeed.